Good evening, everybody. Good evening, esteemed panelists and our respected doctors. And I would like to take this opportunity to welcome all our audience who have taken the effort to come over here. Uh, from Microgen, it's a privilege and honor to welcome you. To start with, as you are aware, Microgen Healthcare was incepted in the year 2007. The seeds were sown by our Honorable CMD Shri Dilip Bhai Parekh and Dr. Faridi. And today, another 18 years, 19 years hence, it's truly an honor to come up with something very revolutionary research presented product that we definitely would want to talk about this later. Uh, Microgen Healthcare, as you all are aware, our disinfectants have undergone extensive testing by both global independent testing laboratories as well as foreign governments to verify the effectiveness against a wide range of pathogens. Our products and services protect people against infections and prevent medical equipments from contamination. Our philosophy, our mission is to become a company that can deliver innovative solutions for infection control and combat hospital-acquired infections in an eco-friendly way. To start with, yes, we have a very interesting topic to be discussed today, and to just give a brief about it. Hospital-acquired infections, yes, that is an invisible threat within all healthcare facilities, small or large. And even the most advanced hospitals continue to fight this invisible enemy, that is surface contamination. Every hospital is facing the challenges of morbidity, mortality, hospital costs, as well as antibiotic resistance. In fact, data shows that 1 out of every 10 patients that are hospitalized does acquire an HAI. Even if some reports suggest not only the patients, we are alarmed, even the staff, the hospital manpower staff. Out of 15, what we understand, every 2 staffs are affected by HAIs. This definitely poses a challenge, and I believe each and every one of you faces that tough challenge, how to interrupt the chain, how to protect every patient from this transmission of the contamination. I'm sure the question everybody does talk about it within the circles is why current disinfection falls short. Disinfection today solves contamination only temporarily, maybe 10 minutes, maybe 15 minutes, 30 minutes. But then after that, what? Though you all have the options today of conventional disinfectants, hydrogen peroxide, aldehyde, there are pros, there are cons. What next? The unanswered question for everybody is, can disinfection continue working even after application? What if surfaces could remain protected not only for minutes, for hours, for days, maybe a week? Is that possible? We do have the proud privilege of introducing a researched, a patented product, D125 Bullet, the world's most preferred green disinfectant. This product is presented with a new technology, that is Hysyn technology, which is a hybrid silicon collagen nanofiber technology, which extends and gives the benefit of prolonged residual effect of the product. Beyond disinfection, persistent protection. The main benefit out of this is today, as the reports suggest, we have the benefit of prolonged residual action till 7 days. D125 Bullet offers precise dilution, hermetic protection, critical care ready, and compact and sustainable. With D125 Bullet, we definitely are redefining infection prevention, offering better infection control, lower contamination burden, improved patient safety, and stronger IPC controls, powered with the Hysin collagen technology. Now, definitely it is a pride moment that something like this has been researched and patented in India, something which is offering a prolonged residual effect. We have already taken a step ahead. If you see in the international circuit, the famous Dr. William Rotella has also been working on this same concept for CDC prevention epicenter programs. In fact, he has also spoken on this with some products providing 24 hours protection. And definitely we are a little step ahead. Internationally, the world is talking about it. As again, if you could see, a lot of papers are being presented for prolonged residual effect. But the question is, how do we take a leading step in India? The world is talking about it. Residual antimicrobial activity is gaining attention in infection prevention and research. And today, we have assembled over here to welcome for the future surface disinfection, future in surface disinfection. We take this opportunity to thank you, and we look forward to an insightful discussion and collaboration on this topic. Let's take this step forward, and I welcome you again for this event. I would now like to welcome our Honorable Director, Dr. Faridi, to give a welcome note. Dr. Faridi.
So thank you very much. Once again, it is my pleasure to meet all the dignitaries and the respected doctors and the faculties. And I'm delighted to have the people, Dr. like Aruna Pujari, Dr. Bansidhar, Dr. Ami, Dr. Shripad, Dr. Tejas, Dr. Mittal, Dr. Urmi, and Dr. Rahul. It is going to be a very, very interactive session, and what we had now introduced in this segment now, what Microgen has done in the last few years in this industry. We were always looking for something beyond and something new and something innovative. So Microgen was working on this subject for last 2 years, and a lot of international trials is going on in this subject, because D125 bullet kind of product which leave the long residual effect, it not only reduces the bioburden, not only reduces the chemical, it also reduces your load and the manpower and the chemical what you do, right? So once you apply a product which remain for prolonged, right? So this was just an initiative, and I wanted to panelists to please come and please, yeah, please join.
Let me take the pleasure of welcoming our panelists for today. First of all, someone who needs no introduction, a very renowned name. Let me take the pleasure of calling Dr. Aruna Pujari from Breach Candy Hospital. She is the director, laboratory director, Department of Pathology and Microbiology. Dr. Pujari has 75 international and national peer-reviewed publications, 10 book chapters, and editor of Anaerobes of Clinical Significance. Next, I would like to take the opportunity, may I call upon Dr. Bansidhar Tarai. Dr. Bansidhar Tarai has a total of 21 years. He is from Max Hospital, Saket, New Delhi. Next, may I take the pleasure of calling Dr. Ami Varaya. Dr. Ami is a consultant microbiologist, infection and control officer, Nanavati Max Hospital. May I call upon Dr. Shripad Taklikar, Professor Additional from Sion Hospital. He's a clinical microbiologist and also an NABL assessor. Let me take the pleasure of calling Dr. Tejas Gohel. Dr. Tejas Goel is a consultant microbiologist and nodal officer, infection control at Leelavati Hospital and Research Center. Next, may I call upon Dr. Milind Dubale. He's yet to reach. Dr. Urmi V. Shah. May I take the pleasure of calling Dr. Urmi Shah, consultant microbiologist from SL Raheja Hospital. I would like to call upon Dr. Rahul Kamble, consultant microbiologist and infection control from KIMS Hospital, Mumbai. We are expecting one more panelist, Dr. Ubale, who should be reaching in a short time. Before that, I would request Dr. Pujari to start with a welcome note, starter note for the discussion.
So, good afternoon, everyone. Good afternoon, everyone. And I think we must first thank the Microgen team for gathering all of us together here for a very interesting discussion and topic. And I think, if I may dare to say so, something like the dream come true in maybe infection prevention, because this is something that we always struggle. Of course, I'm sure that most of us are yet to experience the effects as is mentioned, but I think this is going to be a really interesting topics. And as I told all of them also, you know, we are very eager to hear what comes out of all the experiences that have already, you know, been initiated in different hospitals for this particular product. So I really feel that if this works, this is going to be the dream come true. Nonetheless, we never forget our basics. Stick to your basics and then keep moving ahead. That should always be the way to go ahead, whether it's in IPC or any other field of medicine. So with that, I think it's good time to initiate today's panel discussion, and I'd like to hand it over to my colleague, Dr. Bansi.
Thank you, Dr. Aruna Pujari. So I think this is the first kind of forum where we are discussing the healthcare associated infection and the disinfection part, where this is one of the most important factor in contributing the healthcare associated infections. So like in my hospitals, in Max, I was working in Max Hospital, Saket, where we have lot of, like most of the hospitals we were working have a multi specialty, transplants, ICU critical, where a lot of high risk category of patients are coming. I am also infection control officer, but I always stress and say one thing. See, hand hygiene is important. Also, the cleaning disinfection is equally important. If in my hospital, always I give equal strength to hand hygiene, and second is the cleaning disinfection. So I think this our focus of discussion today is on cleaning disinfection is very important, and we'll see how it goes. But this is where we can prevent many of the, especially ventilator-associated pneumonia and other HIs. So I think we'll have a panel discussion. I think I can sit down. Yes. Yeah. So yeah.
Before we start, may please. I have the pleasure of calling Dr. Milind Dubale on the stage, on the dais. I would request our Executive Director, Dr. Faridi, to welcome Dr. Ubare. Yeah. May I request to start with the session today, Dr. Bansidhar?
Yeah. So let's start. I think first of all, I am very thankful to Dr. Aruna Pujari and Dr. Ami. We both are very high experienced microbiologists and sitting with me and I have requested them to come and join with me. Such an interesting topic, and if you see in the last few years, uh, especially post-influenza H1N1, as after that then COVID. So infection control microbiologist role has a tremendous importance in the hospital setup. And we are doing many things on infection control practices in the last 10 years and many things, and we are trying to achieve at least not reducing, but we are preventing increase in the hospital acquired infections in many cases. So my first question to Dr. Pujari is like, what are the key factors that continue to drive this HI in the infection control practices?
So, thank you for that question, Dr. Bansi. I think it's a very, very important question for us to, keep going ahead when it comes to IPC. So IPC has seen a lot of advances in the last 10 years, whether it is UVC, whether it's so much of automation. There's also AI that is coming in, which is being used for monitoring. And yet there is one basic thing about IPC that will remain, was there yesterday, today, and will always be there tomorrow, is you and me. We are human beings. We are healthcare workers, we are human beings, and it's very, very difficult to change human behavior. And that is one key thing that, probably is one of the most important barriers that we face. You might go and train people, and yet, your hand hygiene rates would be 60 or 65%. Yes, many a time. So probably, it's the capture effect or, the Hawthorne effect that happens, that you might even get 65%. So human behavior is one of the key factors which actually pulls us behind when it comes to compliances. And that's where the importance or the utility of maybe automating a process or something like this, as we are discussing today, whether there could be better residual action, which can remain for a little longer time, so that that human behavior component is kind of nullified. The other things that could be there is, per se, infection control is still not given a lot of importance in every healthcare setting. We still think that infection control mein kya hoga, we still think that why should we give a full-time ICN? What is the need? Can we include this person to do 10 other things? So that's another thought process that comes from the top, where people are not ready to provide resources to infection control, which is actually a very important aspect of patient safety. So I think, in a nutshell, if I were to say, it is basic human behavior from top to down, where infection prevention is actually being pulled behind. How much ever you automate, there's also education, awareness, right from top to everyone who is a healthcare worker. They need to understand that IPC is very important. It's one of the key pillars of patient safety, and we should do everything to prevent even a single infection that you could actually prevent. So thank you.
Thank you, Dr. Aruna. But like what she says simply, so infection control is everyone's responsibility, number one. Hand hygiene we cannot achieve, not even 50%, 60%, we show the data 95%, but that is not the true data. Third thing is, we have to move ahead. We have to some innovation, new things, the long term, like basically the cleaning disinfection part or something like. Now I'll move to the second question to Dr. Ami. But like, we are in a hospital as a microbiology infection control officer, what challenges, what Dr. Aruna Pujari, the manpower in ICA and so many, even our role goes like to a housekeeping, GDs and engineering, F&B. So as a microbiologist, we have to approach, I know just came from Nanavati, we have to fight for even one technician. So our role is always a multi-approach things. Like, so my next question exactly to Dr. Ami is that, how important this multidisciplinary approach in having to better HI outcome? Like, what is your thought on this?
Thank you, sir. At the outset, I'd like to thank Jayesh and Microgene for giving us this opportunity to actually meet everyone, and that's, I think, that's the biggest learning. And so, having said that, I do feel that multidisciplinary approach, be it cricket, be it FIFA football, I think the team is the winner, not an individual person. So I do feel that as a multidisciplinary approach, each and every one, as he just rightly said, that is responsible. And over the last 10 years, I have found that there is a lot of importance also given by the management to this infection control and prevention. Otherwise, how would we be sitting here in a crowd like, platform like this? And a lot of immunocompromised patients who have increased, especially transplants. Whether liver, at Nanavati Hospital, we are doing liver, kidney, and all the other transplants, BMT. So these are extremely sickest of the sick patients. If I have to say this is the tag that I get to hear all the time. The sickest of the sick, and that's where a disinfectant like this or a product like this is something where I would really want to understand, how it can help, and if it's a prolonged action, as very rightly said, I think it would be very, very interesting that, we should go ahead for this. So multidisciplinary approach, that everybody is responsible, that's one. Second, the awareness is also very important, that I'm doing this not only for myself, to save myself, take care of myself, but my patient and the environment. So very nicely that the introductory speech was eco-friendly. And I think the Make in India thing is what takes the key. So I think multidisciplinary approach is for all of us, that together we can do it.
So thank you, Dr. Ami, how important we have to take everybody, manpower, hand hygiene, cleaning, disinfections. In fact, cleaning, disinfections, I usually give more preference because I have an indicator. Especially we have a hand hygiene indicator, but especially I developed a checklist, and on monthly basis, my ICN has to see what percentage of cleaning, disinfecting in each ICUs, and we present a monthly data also as a quality indicator perspective. So that is another important thing. I always give equal importance to hand hygiene and cleaning, disinfections. So now, my next question, Dr. Rahul, is that, so what you see the biggest gap between infection prevention guidelines and implementation? We make guidelines. We are sitting in the hospital or lab, we make guidelines, but implementation is another very difficult challenges. So it maybe has to be guidelines, has to be discussed with them, or training, lot of challenges we have, but implementation is, that's why we are not able to achieve more than 50% of the infection control. Even the AMS program also, we may write surgical antibiotic guidelines, but the surgeon follow different things. Either better you discuss with them and made some changes, and then your compliance will be high. So Dr. Rahul, this question is to you. Yeah.
Very good evening to all, and first of all, thanks to the Microgen team for the kind invitation. It is indeed a pleasure speaking at this esteemed platform and to be a part of the esteemed panelist. I will answer. Thanks for the question, and it's a good question, and I will answer this from my experience. I was a project lead for developing hospitals across India as Center of Excellence in Infection Control and Antimicrobial Stewardship. And there are about 11 hospitals that are certified as Center of Excellence, and this project was awarded and was presented in the International Conference of Quality. So these 11 hospitals across 7 states of India were just secondary care hospitals, tertiary, and it was challenging to develop them as infection control. There was nothing like infection control. The change that we did was training, feedback, audit, and aggressive, effective training, audits, and feedback. It is said that eyes cannot see what the mind doesn't know. So our major focus was training, effective training to all the classes of these healthcare professions of these hospitals, train them, audit them. We did aggressive audits, and training included on-site trainings, webinars, CMEs, workshops, trainings, certified trainings, and trainings from third parties like Kaho, Melap, and others. So our major focus on trainings, make them aware what is hospital-acquired infection, what is infection control, and why they need to practice infection control. For example, a patient with diarrhea and dysentery, why they need to do hand washing to prevent them from such multi-drug resistant pathogens like Clostridium difficile. So when we make this healthcare professional realize that we have to do infection control to protect us also, not only for the patient but for us also from the hospital-acquired infection, they will realize the need for infection control, and they will this will develop the sense of accountability, responsibility, and that will bring the change in the culture. As ma'am said, it's a behavior issue. So that will bring up the training, feedback, and audit, and will bring about the change in the behavior, and will help us solve this challenge of compliance to the infection control. Thank you.
Thank you, Dr. Rao. Like rightly point, training, audit, and this feedback, lot of things. I remember, like, if you see infection control practice, our core, the base level is the GDA, the housekeepings. We have to make housekeeping or GDA tool. I remember we have made a GDA tool for cleaning disinfection of these ventilated side equipments. We have made 30 GDA and make a separate training module for them. How we have made in Hindi or English or local language. And audit is very, very important. See, implementation audit part, you have to do a cross audit weekly or twice weekly. Then you will know what is the real implementation, what are the real challenges. Even the AMS program also, when I done audit in the emergency, it is not the ICU who is getting highest restricted antibiotic. It is the emergency who is using the antibiotic left, right, center. So when you will audit, you will really see what implementation part, what is the training. So these are the many challenges you will get on the guidelines and making guidelines and implementation part. Now let's go to the next, Dr. Tejas. What you feel in the next 5 years? What innovative things and what greatest changes in the infection prevention part?
So I would like to thank Microgen. I would like to thank our CEO, Dr. Uttamani. So I just want to mention that from management side, he is present here attending this. So rest assured. So I am assured that he gives importance to infection control. And coming to the question, so as Aruna madam rightly mentioned that whatever automation comes, after all, rest human we have to do. So if we don't do hand hygiene, then infection is going to spread. None of the automation is going to prevent that. Second thing, for surface disinfection, any of the automation comes, there are few automation like robot disinfection, UVC and all, those are coming. So what future after 5 years, what we see is there might be some development of those automations, like hand hygiene. One equipment was there for monitoring, not for hand hygiene, but monitoring the hand hygiene round the clock. We right now monitor the hand hygiene with the help of ICNs or ICLNs. But if we have monitoring round the clock for 24 hours, then it will definitely pinpoint the particular healthcare worker who is not complying. So we can give training to that particular staff. That can be possible over a period of time in coming years. And coming to surface disinfection. So surface disinfection slowly now see, if we see the disinfection part, back in 10-15 years we were using formaldehyde, then we stopped, then we started using glutaraldehyde, then we stopped, now it is orthopaldehyde. So we are going more towards the greener side. So I can only say coming in 5 years we may get rid of the chemicals, or we may come up with such a chemical, those are greener or not causing any harm to the humans or healthcare workers. So likewise that is possible. But robot and all, again, we had a demo in our hospital itself for a period of 2-3 months, but it is very challenging. So there are many pros and cons related to robot, and a human surface disinfection is not going to compare, means we can't compare that robot with the human disinfection. It doesn't goes in any corner and all. There are it doesn't cover the roof. So there are many things related to automation. But in automation, we can only go greener. We can get rid of chemical disinfection, and there might be some upgradation of robot. In a form of robot only it will be coming. So that's it. So we may go more greener.
Thank you, Dr. Tejas. Look, you are lucky that leadership, see, always in the infection control, and we see if your leader is with us, so anything we can get in the budget, infection control budget. Dr. Uttamani was like, sir was saying, I was hearing that if this long-term disinfectant could have been there from COVID time, then it was like very good. This is a challenge.
Never mind, we have flu still.
Yeah, actually flu is
Right?
yeah. What I feel, flu is yeah. COVID was coming initially, but now flu has overtaken that. Flu is saying I am the boss. From 2009 I am there and I am the boss. COVID was coming, little but high was there, but now again the flu has dominated, and he's still the influenza is influenza. I think that is another thing, and this long term, my question now next to Dr. Millen, what do you think this long standing antimicrobial surface technology? Initially, I think we have a lot of metals and something, but I think long term technology on disinfectant, I think this is the first kind of things which it can persist for longer period of time.
So when Basant met me and he talked about your product, first of all, I'm very sorry coming late, and thank you to Microgen. So I was little when he came to me and said ki this is what the product is, which coats the surfaces, and it has a residual effect up to 7 days. So I was very much against. My first question in mind was, what about the tolerance? What about the antimicrobial or resistance? What if it becomes ineffective and organism becomes smart in the future, and then whether it will be effective in long run. So that was lot of question in my mind. Then as such, quaternary ammonium compound is a low level disinfectant. Okay, and the most worried part is, few of the organism like Pseudomonas, Burkholderia, and Mycobacteria. Okay, so this was my concern, whether it able to eliminate them. So, but then we are talking about the surfaces, and cleaning of the surfaces. So why not? So I tried in my lab, and it was surprising. It has got a residual effect. So then I said, wow, what is it in the product? So they said it is a polymer, okay, which binds the But then when routine disinfection practice is concerned, my worry is whether that disinfectant is in the right concentration, okay, and that requires training and monitoring. So if I train a ward boy, he has to perfectly take the right amount of the disinfectant and right amount of the diluent,
Right.
That is the first thing. Then second thing, how he applies, whether he keep that surface wet. Now we have a habit of, when my maushi comes into my home and then she just mop up, and first thing she does is to switch on the fan, which is very wrong practice, So, so I always say, don't switch on the fan. Even in the hospital, we have that kind of, behavior. So we have to keep the surface wet, Then he had some, so one vial we mixed with one, say water, and he just coat it and make it wet and wet. So that is the simplest thing. But then long-term concern is still there, sir. I have a concern what will happen with Pseudomonas, whether there will be biofilm formation in the future, whether this microbial will develop resistance or maybe tolerance, that is also. And somewhere reference I found that there are genes which will cross and can develop a resistance too. So that those are my concern. But nothing but then there is effective product. So one product I have found is this titanium dioxide. That is also... Right. We have conducted many experiments on that, but this is one of the, what I will say, sir, it should be not a permanent measure. It is an adjuvant to the routine disinfection practice. So you should not stop the routine disinfection practice. So this will act as an adjuvant for the where we know where there is a stringent, like government hospital like me, where the disinfection manpower is the challenge.
Yes.
So and the frequency of disinfection is very poor. So in that case, it might help. Yeah, thank you, sir.
Thank you, Dr. Millen. So basically, these challenges will have, I think, next question, I think, Dr. Sripath. But what this D125, when they came to Microgen team, came to me. So I have initially done two. One is the laboratory study. One is that one ICU pediatric CTBS I have studied. In laboratory, I have done the dilution and kept that dilution for 8 days. So every day I usually put these 5 important MDR box like Klebsiella, Acinetobacter, Candida auris, one atypical Mycobacteria and Pseudomonas. I think that was negative when I reach subculture, and every day the same from original dilution I do this, and almost 8 days it was giving effective. I agree with Dr. Melen that we have to have more study and more approach. Similarly in pediatric CTVS, I think 3-bedded I have done the study, but these are initial stage. But if it is do and it is helpful, I think it will be one of the game changer in the future disinfection purpose. Now, yeah, please.
So because you've done all this, I have been saved from doing this. So I only have to copy you.
Thank you, Dr. Ami. Thank you. So Dr. Ami was saying she has requested so many times to visit her hospital, but today I got the chance to visit her hospital. So now my question to Dr. Sripad is that we are doing the disinfectant. So my question is where we have to do different cycles. Like in the ICU, we have to have 3 shifts, where in the wards we do 2 shifts and disinfectants. So we have a housekeeping, we have a GDA, housekeeping do floor level, GDA do bedside equipments. But if you see in a 1 ventilator patients and you do a proper disinfections in ventilator patients with bedside, it takes almost 25 to 30 minutes if properly done. But which is cannot be done because they have lot of work. They have to take the samples, they have to make some tea, coffee or something like in a government. So what challenges, Dr. Sipat, you say about this routine cleaning disinfection in your hospital?
First and foremost, I would like to thank Microgen for inviting me for this discussion, and may I take this opportunity with the permission of the chair to recoin or reframe the word as disinfectant stewardship when we are talking about disinfectant. So when we need a right disinfectant, right concentration and right contact time. So that's the first thing where we need to specify the disinfection, be it an ICU, be it an operation theater, be it a ward, be it a hematology center, whatever. So we need to have a proper SOP with the right disinfectant for that. The biggest challenge, as you have mentioned, is the multiple cycles. We are working in different shifts. The people who are coming, they're literally been picked up from the Naka. Means, you also would have experienced it in your hospitals. Who doesn't have any idea of how it goes in the hospital? So the entire training, because if that person has been put in the night shift, your entire training for the day batches goes waste, because they are going to mess up by the next day. So there comes the role of compliance. How do we check the compliance? It could be with the help of ATPs, fluorescence, or by direct observation, which is again difficult in the shifts, and cultures, a difficult task to do in the shifts. What remains in our end is training, training and training. But where if this people have been coming up from an uneducated background, we can tie up with the third party. Means that's what I have done in my corporate practice. The agency which is being given the contract, they have been told in writing that any person who has been deputed in the hospital has to have a basic training in infection control and biomedical waste management. And it doesn't take more than a couple of hours for them. So they know the basics of it. But for all these things, what you would need is budget. And I'm really happy to see CEOs of the hospital who are taking keen interest in it. Because again, that is a crucial part when it comes to any BH or any BL, because where we need to show the budget for the infection control practices. And when we are training or retraining, rather than to check whether it has been done, we can change our tone into, can we demonstrate how it has been done? And that would be way forward with a disinfectant which has got a residual action. Thank you, sir.
Thank you.
One thing that we do less in infection prevention is competency assessment.
Yeah.
For actually, the things that they're supposed to do. Many a times we think competency assessment is for, people who are educated, but I think we should also do it for our
So you have partly answered my next part.
So thank you, Dr. Sipat. So actually challenges is that, like if you are using the hypochlorite solutions, how the housekeeping they make dilutions. I remember I've done training. I have given a 5 liter jar. I mark 4.5 water, 5 liter, like 500 ml hypochlorite, 10% solutions, and they have to made the housekeepings. Like another important thing, like even plus hypochlorite or D125, the housekeeping they have to take indent from the nursing. Like, but in our hospital we have made separate housekeeping. They have to indent themselves, or nursing GDA they have to take from nursing. Like, so we have made separate. Otherwise, what anytime you say something, I did not receive this, that was in locker, or some disinfectant was locker. So lot of challenges. ICN knows very well. They go to the base level, and how proper cleaning disinfection is so difficult, and the dilution they also they're difficult. So we have lot of challenges. But yeah, please.
So I just wanted to add that, you know, from the Dakkan map, the cap of the thing, we started, and now to a jar which is marked. You know, this measuring cylinder which is marked. We've come this much, this far, and I think that's a great achievement. And as everybody said, no, that the top management is sitting here. So I think that's a lot of importance given to infection control and prevention. So I think we've come a little better than what we were.
Yeah, I think that after first round I'll take his input, CEO sir and Dr. Neeraj. But my next question is to Dr. Urmi, like what with the increasing MDR box, especially what Candida auris or even Pseudomonas, and do you think that our approach of environmental disinfection needs to evolve beyond this conventional cleaning disinfection?
So first of all, I would like to thank Microgen for giving me this opportunity. And probably after 5-6 years, I'm meeting Aruna madam and Ami madam. When I came to Mumbai, this was the first person I met. So thank you, Microgen. So if we see pre-COVID and post-COVID, the microbiologist and the clinical microbiology per se was not that important when it came to post-COVID. Post-COVID, if you ask someone that who is the microbiologist or what is infection control, probably people answer. People know what is hand hygiene, how to wear the mask, because post-COVID microbiology and infection control has gained importance. लोगों को पता है हॉस्पिटल में माइक्रोबायोलॉजिस्ट होते हैं, उनका ये काम होता है. That after COVID. So if you see the PG seats also after COVID, lots of people are getting admissions in microbiology because this is one of the important branch and has importance in the hospital. Now, if you see the question like MDR organisms, so when we were doing the residency or even in the Mumbai before 7-8 years, when we see our reports, it was like the sensitive bugs. We were not getting that much resistance. Even meropenem was sensitive, magnesport was sensitive. But nowadays, if we see even in gram-positive organism also, we were seeing that we were not getting any vancomycin resistance, or we were not getting fully drug-resistant Staphylococcus aureus. But now, if we see our report nowadays, we see many reports where all the drugs are resistant in that organism. I mean, what we will give? There is nothing to give. I am from a diabetic institute. I am from Raheja. So we get so many polymicrobial infection in diabetic food. So many because of the biofilm formation, or patient is very chronic, hospital, community acquired, hospital acquired, because patient come from toe amputation till the below knee or above knee. To us only. So multiple organisms with multiple drug-resistant organisms are there. So prevent that, we need something in the hospital, whether it is lab, whether it is OT, whether it is ICU. We need something that routine cleaning is definitely necessary. Like whatever routine cleaning and disinfection, we do it with hypochlorite, hydrogen peroxide. We do it regularly. That is necessary. But somewhere down the line, we need something that decreases the workload of housekeeping staff, because whatever we say कि हाँ एक shift में 2 बार या 3 बार high touch surface को clean करना है, but they are not going to do it, and they are not doing only. It is just our perception that they are doing, but they are not doing. We all know. So to probably decrease their some workload or increase our efficiency for infection control, this kind of product may be useful. I have used this product in my lab only once. So when they came, even I was surprised, like, sir, that no disinfectant can work for 7 days. It's not possible. So I used it in incubator, which is a microbiology incubator and which is fully contaminated because all the microplates goes inside. So we used it. We took pre-op swab, pre-procedure swab, and we took it for first day, third day, and seventh day. Today is the seventh day actually, so took it today. So for the first day and third day there was no growth, and for the first day there was a growth. But still we have to check more and more what is the action of this particular disinfectant, because अभी भी वो विश्वास नहीं आता कि ऐसा भी कुछ हो सकता है where the 7 दिन तक कुछ भी नहीं होगा, 7 दिन तक there is a residual action which company is claiming, which manufacturer is claiming, but if it is there then it is dream come true, as madam rightly said in the starting, that it is a dream come true for microbiologists or any infection control officer, where we know that disinfection and cleaning is actually not happening. If you see the OTs, we get very 10 minutes consultant say abhi OT lena hai, fatafat OT lena hai. There is a practical difficulty because one consultant comes, he goes to other hospital, he goes to other hospital. So he wants to complete 3-4 OTs in that 1-2 hours. So ideal dekha jaye to we should have half an hour to 45 minutes between 2 OTs, which is not possible. We get hardly 10 minutes, 15 minutes to do the surgeries in between, and we don't get the time. So if this kind of disinfectant is there, then we are sure that something is doing their action, and we are free at least for 5 days or 6 days. कुछ अगर in between थोड़ा कम करेंगे या नहीं करेंगे तो there is some residual action. But again we need more and more confirmation and more papers or whatever. We try, and then
I think even one day of proper with this type of cleaning disinfection with having residual effect, I think that will be also game a lot of importance, because every like what Dr. Urmi is saying, the surgeon give only 5-10 minutes. You have whatever you have to do in that time. Every hospital has it. Every finance is first priority and second is so we know as an infection.
Microbiologists are nowadays given importance.
Yes,
Finance is secondary, but we are getting the budget nowadays post-COVID. So
That's good.
it's really good.
So basically our infection control for us, our leadership, our management is so important, and we are very lucky. We have Dr. Neeraj here. This is the first round I have completed. I think we have another round. Before that I have some inputs from Dr. Neeraj. Mic please.
Good evening everyone. Maybe it's more of a forum of microbiologists, nurses, people who are actively involved in infection control. I would like to highlight 2-3 important things. First and foremost, thanks to Microgen, Mr. Raju, Mr. Jayesh, Dr. Faridi, all, for conducting such a nice conference where the forum is really looking complete to me. Now I would tell you what our pain is. You all said management support. We require your support. You know the type of turnover our beds require, especially patients waiting, in OT for beds, for ICU beds. For me, our hospital most important person has become Dr. Tejas. He is the one who guides, what is the mode, how we'll go for infection control, all projects, anything related to hospital renovation, ICRA has to be filled by him, otherwise I don't give signature for finance. So now it is other way. Infection department can take up the major share of budget. It is not only the importance of budget, it is important the overall lifestyle. It is, again, people used to think it is only microbiologist and nurses' duties. I am thankful my chief of nursing have come of ICU and OT. So this makes the team complete. But I would tell you, infection control is something which starts from CEO and ends at the security guard. The system, the hospital environment is such infective environment. Either people are coming for an infection or for treatment of some infection. If this entire chain is not supporting infection control, then somewhere you are lagging. somebody was right, it is coming from people coming from Naka. Madam also mentioned the similar experiences. Rightly so, but what to do? You can't have a graduate coming for a security guard post or a ward boy from some MSc background, right? So you are going to get those 10th and 12th pass, or sometimes not even that much educated people for this work. You have to manage with these workers. So you'll have to train. The microbiology department has to be most active department in the hospital, and I would actually go to that extent that we should have good number of microbiologists, not only one microbiologist. It has to be you have for intensive care, you have 10 doctors. And when it comes to microbiology, hospitals are so choosy, they just go for one microbiologist. Fortunately, because of Dr. Tejas, we are now a strength of 3 people in our microbiology department. So this is entire ecosystem which has to improvise. It is, everyone has to think about it. The infection control has to be a priority, because then other things are so positive in your hospital or in the society. Again, all quality parameters, be it NABH, we are the only hospital, Lilavati, which is JCI 8th standard certified hospital. You go through the books and standards of JCI and NABH. I think now first chapters are infection control. First. Second, obviously, is patients fall. But first is infection control. And so much importance to even a smallest activity being done, ICRA, and then project related clearance from infection control, everything has to be taken. So, in fact, the JCI accreditor, Dr. Anthony, who came from Japan, he was only interested in talking to Dr. Tejas, not to me also. I was in fact feeling, what is this yaar? He is not asking my statistics, kitna patient hai, kya occupancy, where is infection control nurse, where is infection control doctors? He was just interested in talking to them. So this is the importance of quality. Now comes a problem what you are discussing, and rightly so. In fact, I am enlightened with good discussion from you all. I am thankful to you all, because it was an excellent discussion being carried out. I think I should continue listening to you rather than speaking more. But there is one thing which is very important, that you cannot monitor finally whether surface disinfectant has been done or not. See, there are 3 possibilities of organism coming. One from air. You are now very fine filters. You have taken care of that. And then, the second possibility is the surface. The third is hand hygiene. I am so happy that the company has come up with such a nice product which has 7 days of residual effect. We are testing it in our hospital. Dr. Tejas is the principal investigator in that. We are testing that in our ICU, in our rooms which are used for barrier nursing. We are also using it for organ transplant rooms. Now, if something which, so the night guy, what somebody said, night guy is not doing the same type of disinfection. If I can have such an agent which takes care during the morning, an expert is doing this, and then it takes care for 7 days. Something which should, I know it has to be studied further, but if that is the case, we are absolutely fine. In fact, I was discussing with him, why can't we have a product where we do hand hygiene, and at least that hand hygiene stays for 1 hour. If we can have maybe on similar technology, I don't know.
Yes.
Some what technology? It's I feel
Fluorescent
technology. What?
yes.
So, yeah. So once again, thank you to all the microbiologists. I believe for you all, my doors are always open to come and discuss and give good advice to me. Whenever we would be welcoming any good advice from the Learned Forum. Thank you.
Thank you, sir. Thank you. Very informative. See, JCI, if you see standards, the infection control is the largest. We have all everything will be come under जैसे housekeeping will come under जैसे engineering will come under F&B. So any infrastructure maintenance issue, all these things cleaning, even though they go in deep into it, like what is the sinkage, water tap or sinkage, they will go to see the dust, anything dust is there. So everything, even you are doing best in HI, hand hygiene, but all at least NC will come in infection control. That is sure. That is sure.
So sir, basically, madam was telling about competency, no? So though it is not covered under NABH, but JCI sees all this
JCI.
competency of
Yes.
each and every staff, whether it is housekeeping, engineering, or nursing. We have a hand hygiene competency also. So likewise, competency has been taken care if we have JCI.
They also ask for individual components of the hand. They see the indicator.
Yes,
graph,
yes, yes.
individual component.
They see whether they are displayed,
Yes.
whether it has been discussed, whether that particular staff knows the hand hygiene percentage of that area, and if it is less than the previous month, then what you have done now.
Right.
So likewise,
Yeah, I think that there are a lot of things. So I think we'll go to the second round, and after second round, I'll give some chance to audience. But now my first question to Dr. Aruna Pujari, like in my experience, all HIs, the most difficult is the ventilator associated pneumonia, and we got multiple MDR box, like even also Acinetobacter baumannii, Klebsiella. And when I do a RCA, so mostly they come under cleaning disinfection is not being proper. Like Klebsiella, Coti and other bundle compliance issue, and that is the major RCA. But in ventilator associated pneumonia, see the cleaning disinfection part is one of the most important RCA what I got. And for the question is like in this multi-drug resistance organism like Acinetobacter baumannii or Candida auris in Klebsiella and all these high-touch surfaces, they reserve for weeks or long they stay. So how significant this environmental surface reservoir compared to person-person transmission and causing all these HIs?
Again, a very important question, Dr. Bansi. I think you have initially also said, and multiple times, a lot of us have pointed out that hand hygiene and environmental cleaning are the two pillars of infection control, and they are also related. They are related by moment 5 of hand hygiene. Moment 5 of hand hygiene says that the moment you are touching the patient's surrounding and then going back to the patient, you should do hand hygiene. So, what are the reservoirs? The reservoir is hands of healthcare worker, and the reservoir is the environment. I don't consider the air to be a major component as a routine, because most of our flus etc. also are basically droplet based. The droplet will settle on some surface. So the indirect fomite based transmission is one of the very, very important components of almost any and every HAI. And you mentioned about the viability of these organisms on surfaces. I recently read a paper in Journal of Hospital Infection, which was I think just last year published, and they have found Klebsiella pneumoniae remaining present viable on a surface for 180 days. And I was shocked to see that, because we always thought that Klebsiella is a little water loving types, and Acinetobacter can remain on dry surface. I know MRSA and Staph aureus can remain on dry surface and so on. I was very shocked and surprised with Klebsiella, because if you see today, number 1 pathogen for us in the ICU is Klebsiella pneumoniae, which is resistant to carbapenems. And Pseudomonas and Acinetobacter are equally big foes actually, because they are also multi-drug resistant. So the environment is a very, very important reservoir. For example, if you look at C. diff, it's the environment which includes the curtain and the linen, which needs to be changed as part of deep cleaning. Okay, so the environment is a very important reservoir, though it's just that we are not able to probably see the organisms, and that is the reason why sometimes people don't do the processes of cleaning and disinfection well. But these are the two most important pillars, and the environment plays a very, very important role in harboring organisms and keeping their viability. And there's plenty in literature actually to say VRE, C. diff, Klebsiella, Acinetobacter, Pseudomonas, Staph aureus, all of these pathogens can remain on surfaces, on dry surfaces, viable. That means you pick it up and you put it onto another patient, or you put it onto a culture plate, it will grow. So they can be viable from 2 months to 6 months, and that's something which is, Klebsiella was certainly a new learning for me. I never thought Klebsiella would remain, but that shocked me, because today the number one pathogen to us is actually Klebsiella, XDR. COVID also stays, most viruses, but then if the surface is dry, probably the viruses will die because they are intracellular.
Not more.
But yeah, but it
COVID.
not for if it's dry. If it's dry, probably it does not remain, because they all require some kind of cellularity to be present. But for bacteria, it's not like that. They can remain on surfaces for a very long time, and the spore bearers are definitely deadly.
Another thing is that we found that the curtains which have been used, no, they are one of the important carriers for MDROs, especially Acinetobacter baumannii and dialysis unit patients that, it is even being published. So not only as a rail and hospital beds and all, but even including curtains and the knobs of the door and all that, they are also equally important when it comes to infection control.
We probably didn't talk about frequently touched surfaces, and we talked a couple of us also mentioned about high touch surfaces. I think this kind of an intervention would be very, very important, because high touch surfaces many a times are small surfaces. They are not very large surfaces, and people will actually forget to do C&D for them. So such an intervention is certainly useful there.
Aruna, I remember in our KM days, our CVTS was closed, because of Acinetobacter, and the source of infection was all these curtains, files of the patient, linen, and then we had a very hard time, and every patient getting infection. So ultimately we closed down, had a renovation, and then that's how it is eliminated. It's very difficult to eliminate.
Yeah, I think high touch, I think the next question, Dr. Ami, is the high touch surfaces like the bed rails or IV pool monitors or light, the switches, they are frequently get recontaminated within minutes, even after normal routine cleaning disinfections. So what inter-cleaning contamination window patients outcomes and extended ICU stay. So what is the thought on Dr. Ami on clinical and financial impact of this in recontamination of the high touch surfaces?
Yeah, I think it could not be highlighted more importantly, the fact that when you have an HAI, your ICU stay increases, your finance budgeting increases for the patient. Having said that, it's important that we have this understanding that these are these high touch points, and they are the ones, we've been just discussing that now only, that they are the ones who are carrying the MDROs, and I think a disinfectant product like this would be very helpful, because one, we do not have to then train our staff as much. Once in their shift, if they are able to do it, they'll be able to do a good job on that. With the manpower, as very rightly CEO sir said, that he will not get anybody who is very highly qualified, for doing this sort of a job. So for somebody who is very basically trained, a disinfectant product like this would help us. And recontamination is very high in all these high touch surfaces. So I think a good product, which is as very rightly Shripad said, that the stewardship would be very, very meaningful. So definitely it would help decrease the financial burden if it is it'll prevent the recontamination and it'll do a good product. So.
Right. Thank you, Dr. Ami. Even once a day a proper thorough cleaning of this long residual disinfectant, I think that will be a very much at least once or two, at least 2 days, or even that is also sufficient, because see, manpower will be remain our chances. They are the most targeted, like housekeeping, GDA. Every time they are being outsourced, and the housekeeping, this issue and this that they don't have a fix also. Yeah. So that is another issue. Every time, so we have to say keep this housekeeping in this issue, so that got trained. So let's move to the next.
Another thing, sir, yeah. We are not getting dedicated manpower. That is something that I would want to say here. At least in corporate hospitals, you have general duty attendants, GDAs, And they are keeping, they keep rotating in every shift to every department. We are not getting trained manpower. We are not getting dedicated people. So that's another big challenge in my setup.
We require actually ICN also. Right. ICN, yes, I think they are the main pillar of the infection control. I think we have ICNs here also. So they are the main pillar, and they go rounds and take audit. Proper audit they only do. And I next questions about this biofilm. We see this MDR box, Candida auris, SNO, there are a lot of frequently biofilms with me, Dr. Rahul. So what dry surface biofilms are increasingly detected with the high-touch hospital equipments. So how you feel this protect secondary pathogens from the sharing disinfection, with especially these long-term disinfectants after this biofilm permission?
Thank you, sir, for the question. Post-COVID area, the plethora of organisms causing hospital-acquired infection has changed. Pre-COVID, we were seeing E. coli and Klebsiella, but post-COVID, along with Klebsiella, we are seeing Pseudomonas, Acinetobacter, Burkholderia, Candida auris, and other things. These organisms are biofilm producing organisms, and biofilm is a challenging thing. Unlike detecting other bacteria on culture plates, we microbiologists don't routinely do the detection of biofilms. This is a challenge, and which is causing hospital-acquired infections. What is organisms like Pseudomonas or Candida auris, they develop these biofilms, and biofilms forms a protective layer across these organisms, and which protects these organisms from desiccation and the disinfection action of these disinfectants. So these organisms with the biofilms developed over time acts as mini incubators. So across environmental surfaces, this organisms with the biofilms act as mini incubators, releasing slowly, intermittently these organisms, which gets transferred by cross infection to patients and visitors and the healthcare profession, causing hospital-acquired infections. So detection of biofilms is a challenge, and this is leading to hospital-acquired infections. So product like D125 bullet have you seen the literature? It has an activity against biofilms also. So we will see as we move ahead. We will see how effective it is against the biofilms. Definitely, as compared to conventional methods, this disinfectant with a residual action and with a claim against biofilms will prove very beneficial for our infection control.
Yeah, thank you, Dr. Rahul. So basically, even I remember I'll give two examples how even in the pipes, RO pipes in the hospital, sometimes every monthly I tell the engineering team at least flush with 10% bleach with the pipes, so that the pipes also the biofilm formations. If the patient and another even if the patient is not able, so I sometimes do keep the fogger machine in the AHU area so that that can clean all the dogs, AHU dogs. So a lot of things biofilm formation happens in the environmental part. So now my next question to Dr. Tejas. So you have a JCI and NABH audit. So you have a routine cleaning disinfection protocols. So how will you incorporate this long residual antibacterial disinfection in your protocol and having compliance in the
So just wanted to clear one thing, that infection control we are following in any of the hospital. It is not for NABH and it is not for JCI. Right. Before NABH also we have to follow infection control. This is a basic patient safety norm. And after NABH or before JCI or after JCI also we have to follow. NABH, JCI, this help basically to organize structure, and it is just a process of streamlining our infection control. So coming to question that how it help residual effect. So what is my feeling that, see, in our hospital now we have, for example, in ICU we have cleaning which has been done in each shift. When cleaning is being done in each shift, so we require a residual effect of for 8 hours. If that is being suffice for 8 hours, if we have a residual effect, then for example, we have discussed like hand hygiene percentage globally, national, whatever it is, between something 60 to 75% range. Okay, so remaining 30-35%, if someone who is not following hand hygiene and touching the surface in between this cleaning, then he may not harbor the organism in his hand. So this is one benefit of residual effect in our setup. And for this, if any disinfectant, if have a residual effect, it may not be a replacement of our cleaning process. Because what will happen if we start mentioning that 7 days residual effect, 3 days residual effect, I think then housekeeping staff will become very sluggish. Then they will say that abhi cleaning kar liya hai aaj, abhi 3 din tak nahi karenge to bhi chalega, and there might be some problem. So this is not a replacement, this is a supplementary additional thing, and definitely in between cleaning. The hospital where there is a compliance, where there is a cleaning which has been done vigilantly every shift, there this will be helpful. We require only 8 hours. Now Dr. Urmi was mentioning, Dr. Urmi, that हमारे यहाँ होता ही नहीं है. There might be this 7 days का role picture may come. लेकिन जहाँ पे होता है वहाँ पे we require only, in critical areas we require 8 hours का minimum residual effect, so that it can take over hand hygiene का compliance and whatsoever transmission that happens in between those 8 hours, that can be prevented. Those transmission of organism will get prevented with that.
Thank you, Dr. Tejas, and we'll move the same thing, frequent recontamination in the high-touch surface, Dr. Milin. So how the hospital should address the gap between the routine cleaning cycle and subsequent surface recontamination?
So especially in a high-risk area, the organism gets colonized first, and for any infection, colonization is must, and after colonization, then infection start. So we have to concentrate on these high-touch surfaces like switches, doorknob and all. So routinely what we do is a scheduling of the disinfection practices. So we have a 8 hours duty and then we schedule. So how many times? It may be 3 times or 4 times depending on the area. Apart from this scheduling, we can concentrate on the high-touch surface, and there we can increase the frequency of this disinfection. That is the second part we do. The third part is we should not ignore hand hygiene. So frequent hand hygiene, as she said, 5 moments, 2 before and 3 after moments, before touching the patient, after touching the patient, after touching the environment, and after coming in contact with the fluids or body fluids and all. So we have to judiciously follow, and not only follow, we have to monitor also. And that monitoring is very difficult task. Recently I came across one app which is implemented in Vedanta, and they said ki only infection controllers will carry, and it captures the missed opportunity. So that kind of app and automation can be developed. So that is one of the things we can do it. Other thing is that even after cleaning there is a recolonization. So that is our problem. So how many times you will clean and how many times you will monitor. And then last comes is this long-acting agents, where we can have a permanent coating. So when Javed come to me with this product, the first thing I ask him, is it real? Okay. So the second thing I ask, what is the compatibility? Whether I can apply it on metal, whether I can apply it on soft surfaces or any other plastic surfaces, switches. And he said, yes, it can be applied. I was surprised. So this product has having a proper concentration, contact time is minimal, and the compatibility is also beautiful. So, so this is one of the major, for this highly touch surface, can we have product like this where we can coat this, okay? And as you said, this is not a substitute. You have to continue your routine cleaning disinfection. But few surfaces we ignore, like nursing station. Right. Nursing station pe upar file rehta hai, and then we don't touch it, don't clean it. So in that kind of scenario, this surface, if you coat it, have a 3 to 4 disinfect.
True.
So it's very nice. So yes, definitely this product like this D125 will help. So these are the strategies we can adopt.
I think there are
Yeah.
many areas where this product is needed, like even walls,
Walls.
the stand, a lot of
Stand.
things.
Even,
We have
you
to
know,
make a
when-
checklist where
you
we
know,
can have this.
When we conducted
Yes.
experiment in our hospital, no, he said, Javed said, once you apply, you don't have to clean. Well, how it is possible? we have to clean the surface. So I purposely allocated 1 or 2 surfaces, you know, and talk to the sister, no, you don't have to kill, I am going to carry the experiment. And surprisingly, there was a significant log reduction and it stayed till day 4. At day 7, I got some few colonies. So that's surprising to me.
Yeah.
Yeah.
I think these are new things, and I think a lot of pilot studies required, but it's definitely routine cleaning and long lesson both simultaneously to be together, and we have to incorporate in our SOP, like at least see corporate hospital, then government hospital, at least the government hospital where this is more requirement, but in private hospitals like Dr. Ami knows, we also now have shortage of manpower, GD housekeeping. We need also this type of product. Thanks Dr. Tejas, they have a management support. So so they don't have any problem. But in Max also we have facing this manpower challenges. So now my question to Dr.
Sir, just a minute. I think we should also talk about the computer and the keypad.
Yes.
Because I think
we have to make a check, like I think
checklist.
10-15 items I have made listed, where we have to, I told them specifically, when you are marketing also you have to write it this 10-15 points.
Is there a spray that can be made out of this? Because that I think would be very, very effective when it comes to...
Dr. Farid, you want to say something, or at the end of the second round I'll ask you.
We have some spray and the mini machines which can reach out to the places like the ICU beds and all, railings and all. I think with my team is already demonstrating with that machine, the small machine which can take to the all the places, difficult places where
That's a fogging equipment.
this is a small spraying equipment. This we call as a mini fogger, but it doesn't fog. It helps in to reach out to the places. That's all. Thank you,
Dr. Faridi, like I want to ask one question that is not in the panel. See,
you don't give me surprise.
Yeah, basically what I feel as like we have seen evolving Indian product, like
Right.
I have seen lot of antibiotics like that Wakad, Levonoreploxacin, and that Cepepim. So lot of new, new molecules are coming, and Indian innovation like this product is, if it's work well, it's a game changer.
Yeah, it will.
And so I think the first Indian company who is having this long residual effect and will be over the world. How you thought about this product? How long you took this?
I was tracking this on this subject for a very long time. When we can have the hand sanitizers, like you use hand sanitizer, ethyl alcohol with a chlorhexidine gluconate. One is for the instant relief, and other leaves you residual effect for 6 hours. Chlorhexidine gluconate, by the way, give you the protection for 6 hours, right? If it is not doing this thing. So this thing was going on and on for a long time. I met few top dignitaries in the world, Dr. Rutala, for doing a UVDI 360, what we represent from the USA. So this trial was going on. The John Hopkins Institutes and Dr. Rutala team has published this thing. So something was going there, and we were working on that, how to come out with something which will stay there without harming the environment, without harming all the surfaces what you are using in the hospital. You have all the expensive equipment and machine, and the surfaces is not something which was there 20 years back. So you have all the latest kind of technology and latest machine, so which it should not harm that. So for last 2 years we were doing R&D and F&D on this subject. And sometime this product, when we found this product is a back-to-back patent. Even the binder is patented. Okay, so when we found this product, which is a binder, and it is not available in India, and getting something around 250 grams of this binder in India was a hell of a task. Then we could get something and started doing this thing. But surprisingly, this product was giving me a big surprise because microbiology is my most favorite subject. And when I was observing it, it was continuously working and improvising day by day. So this was something which was a big surprise. Then I called Dr. Bansidhar around a year back that we are working on some R&D for some product, and which is showing me this kind of result. So he also said to me, Faridi साहब ऐसा कुछ होता नहीं है. Dr. Faridi ऐसा कुछ होता नहीं है. It will not work.
I told don't come to my management. Otherwise, my those 8-hour shift that will convert to 7 days, and then my.
Then this was around a year back when I said ki we have developed something, and it is improvising. On the day 2 it is improvising, day 3 is still. So when we got it tested in some outside laboratory, we sent the sample to international labs also. Then finally I requested Dr. Bansidhar. So please do a trial for us, because we wanted to have in the real world condition, not into the lab condition, not into our R&D and F&D. This is how the journey is begun. I'll add only one word, this thing. The generation of quart has changed a lot, right? We are talking about the 7th generation, 8th generation quart, like we have quinolone, when we have cephalosporin, something like this. So this is also improvising. And the formulation is so advanced, and it has been patented twice, and the back-to-back the binder is patent. For the next few years, when Dr. William Rutala has coined this word CAD, C-A-D, CAD, so continuously acting disinfectant, I was really impressed with that, right? So we wanted to get this product tested now, and through him in the US, we are just completing the formalities of getting this product permission to test in the US market. You know that there are some regulations and all to initiate a trial. There's a lot of this thing is there. And one thing I'm very happy, we did a similar kind of meeting at Delhi on 8th, and Dr. Yatin Mehta and the panelists, they asked me that, can you do a multi-centric trial? Yeah, I was really so excited to do that we want to have a multi-centric studies in India. That should be the first study going from India to Western world. I'll be very happy if some panelists join for this multi-centric studies, and Microgen definitely is going to work for that. Thank you very much.
That's great. I think we should, that will not delete that group, WhatsApp group, we'll keep for the multi-centric study. And thank you, Dr. Faridi. And in fact, one doctor was asking Delhi to just put a made in India like stamp in that product, so that everybody, because see, this is an Indian innovation. Whatever you do, it takes time to accept. If it is come from USA, everybody accept immediately. Even the CLSI breakpoint, we have seen UCAS breakpoint. But like I find, even the CLSI team was there. I would say the enmetazobactam, cefepime, and levonatin. We please incorporate in the breakpoint in the CLSI guidelines, because they don't think like, so that is a problem when we, right. So I think we should move on. Next question, Dr. Sripath. So what do you think if you have a disinfectant like this and multi-day residual and all this cleaning, routine cleaning, how you will rewrite these SOPs and train your staff like on this factor?
Yes, definitely with this kind of product with long residual effect, we would need to rewrite the SOPs, which would differentiate two types of frequencies. One as a cleaning frequency, and secondly the residual reapplication frequency. So we need to differentiate where we can just leave it as a reapplication, but not to forget the basics which Aruna has initiated it, not to forget about the surfaces which are physically soiled or which are having inorganic matter, organic matter along with it. So if it is there, we need to go with a different version. We need to rewrite the SOP in terms of sequence of cleaning and disinfection. We need to rewrite the SOP in terms of if we can use the color-coded tubs for different zones of the hospital which are highly infected, that would be needed. And in any of this hospital-based, we are talking lots about accreditation. 3 things are important. One is qualification, second is training, and third is competence. And it follows in that sequence. Now, when we are not very much sure about the qualification of the people who are doing it, we have to have a great emphasis on training, retraining, and competence assessment. And we have just limited our discussion to competence of the staff, support staff, but JCI also talks about the competence of the consultants. And if it includes more than 23 points where I had read it, 23 questions for the doctors who are there. So definitely it has to be done even for the support staff which are going to do this disinfection. Thank you.
Thank you. Thank you, Dr. Sepa. So my last question to Dr. Urmi on second round, like from an infection prevention and clinical perspective, what potential value could prolong this residual microbial infection offer in residual environmental transmission, particularly in high risk and high touch surfaces?
So first of all, we were talking about infection control nurse. So we were talking about that hospitals should have infection control nurses. But many of the hospital where NABH or JCI is not there, probably the management also doesn't give permission for having ICN and microbiologists. So even in my hospital, we have, I am there, my ICNs are there, but we have a concept called infection control assistant. They are not infection control nurses. They are upgraded housekeeping staff. So they are particularly trained in infection control practices, infection control audits, cleaning and disinfection part, biomedical waste management. So this kind of concept probably is evolving where when you do not have any, probably the degree staff, then we can have this staff, we can send this staff for any infection control training which is happening around, and maybe we can take help of them for infection control practices in the smaller nursing homes or a smaller hospital where NABH and JCIs are not there. If we talk about the question, so this should not be the replacement of routine disinfection and cleaning what we are doing as of now. Generally what we do the cleaning and disinfection and then we wait for the next disinfection or cleaning practices to happen in the next shift. Though this should help in between maintaining the cleaning and disinfection rather than a replacement. So cleaning, disinfection, residual action with this kind of product, and then again cleaning and disinfection. This is how we should practice.
Thank you, Dr. Urmi. So there are a lot of challenges, and I remember 3 years back when I was trying to shift from hypochlorite to microgen disinfection because a lot of problem was happening in the hypochlorite, lot of smells and lot of hazardous. So these gradually I was shifting to microgen. A lot of challenges I faced from the old nursing staff and JDA. So gradually, slowly we go. Lot of challenges. I think we overall cover the second round and we have a last 2 or 5 minutes, only the rapid fire. But before that, I want to ask few audience if there are some suggestion or any questions. If any audience want to give some highlight on, otherwise we will go to, because time is also a factor, so we will go to the last round. So, sir, you want to say something?
I want to say some place we already miss, that is a basic tap water. So we have one experience, that is outbreak in the NICU. And we done the surveillance, there was a Klebsiella pneumonia and there was no growth. So I told them, you check the basin tap water, and from there we grew the Klebsiella pneumonia. So I think this place is also important for cleaning as well as disinfecting it.
Definitely, sir. I have experience on tap water in a pediatric CTVs. I think 10 years back we have 2 or 3 cases, and then I've changed the normal tap water to R water. In pediatric NICU, I shifted to R water because these are very vulnerable patients. So yeah, there are a lot. Yeah.
Many a times you have knobs.
Yes. Now we have to change knobs, filters, and sometimes UV you have to put the higher than that.
Within
that
the line,
in
in
lines,
line,
in
if you
line.
put UV also helps.
So we'll move to the last round. Residual only just 30 seconds. So I'll just read it out. As infection prevention continues to evolve, what is your perspective on the role and importance of prolonged residual antimicrobial efficacy of disinfection in preventing HIs?
We'll go ulta.
Ulta, yes, from that side. Dr. Ami. Yes. And just one word, one or two words.
So I think it's teamwork with management to begin with, and making it important for all of us to follow this basic principle of infection control practices. So I think that's my take home, or my understanding would be that a teamwork is always more important, and the winning team is always the one which celebrates.
But one word on importance of prolonged residual antimicrobial efficacy. On that
Sir,
one.
abhi iske
Okay.
liye to let us just do it and
Okay.
and tell you
Great.
after that.
Great. Next.
So no matter if you even if you have a good product having a residual microbial action, but I will stick to the basics. That is, I will tell sterilization is incomplete without disinfection, and disinfection is incomplete without cleaning. So that is the basic. Sir talked about CAD, continuous action of disinfectant, but then I am worried about what you pointed out. What about those organic matter, whether we have to remove it, whether it is become less effective in presence of, so that is my concern. And in long run, my concern is again, what about resistance? So that is my concern. So yeah, but having this product and let us use it, and definitely there will be effect, by reducing the hospital acquired infection.
The question now is not that which disinfectant will kill. The question is which disinfectant will kill and continue to protect. So conventional disinfection was just killing the bacteria, but D125 bullet will kill the bacteria, which is residual and biofilm action. It will continue to protect us. So it's like a boon in infection control.
Right.
It definitely forms important extra layer on whatever we have this product, but again we should not forget the basics. And second thing is, he said that what is the future if resistance develops, so we need to keep that in mind, because whenever the new antibiotics comes, after 6 months we see the resistance, so we need to continually evaluate this product and hope so it doesn't get any resistance.
Already we have discussed everything. So considering that we will not have 100% compliance from cleaning and disinfection from our staff, considering we will not have 100% compliance in hand hygiene from our healthcare workers, definitely this residual effect has a role to play in this scenario, because hand hygiene, again, it is a behavioral problem. May not be behavioral problem in few percentage, but it is a behavioral thing people don't do many times. And housekeeping, again, those staff are not educated and all, and it is not a chosen job. Basically it is not a chosen job, so we can't expect 100% from them. कितना भी ट्रेनिंग ले लो हमारे in लीलावती we to have so much attrition of those staff कि it is very difficult to maintain that. So considering all these challenges, definitely residual effect has a role.
Good product, job is 50% done. So that we can start with.
Right.
A good residual effect, 50% work is done. We have to work for rest of the 50%, which are high touch, carrying drug resistant bugs, and definitely reapplication frequency or SOP for reapplication would take care of that also to some extent.
So for me, like it is a residual, if it will be a game changer if in the field of disinfection, like we have Gene Export, Biofire, Kaistat. I think for disinfection, this will be a game changer if it acts. Last and final conclusion, Dr. Aruna.
Thank you so much, all of you. I think for this question that you asked all of us, I think there's no one-stop solution to anything, anywhere. Risk assessment will be important, and I agree. I think for me, frequently touched surfaces would be the place which is probably, where this is going to be extremely important. Now, coming to some things that I thought, we've already, pointed out occasionally, tolerance. I think I'd really be worried about that. अभी तक हम बोलते हैं कि वो surface पे the organism doesn't multiply too much, so therefore, don't think about resistance. But here there is something which is acting continuously, and under that pressure, that's the same antibiotic pressure that happens in the body and we develop AMR, whether that pressure of the disinfectant is going to make the organism, change. So that would be definitely our concern. Microbiologists can be sometimes pessimists, but never mind. We should keep that in our mind. Compatibility with other disinfectants, because we've all talked about this can be used in certain situations, maybe once, and then you have to have a routine SOP, because you don't want to tell everyone, अरे 7 days, तो जो होता था वो भी नहीं हो जाएगा, भूल भी जाएंगे लोग. So I would, want to understand what is its compatibility, whether, the next agent to be used is going to be the same agent but without the bulletproof. Okay. Then the third thing would be compatibility with biomedical equipment. So that's also another concern, your nebulizers, your IV infusion pumps. We use them so often, IV stands. They're so often used, but they're also not cleaned, disinfected, whatever. So whether there is compatibility with all of this, and Dr. Faridi already mentioned, that you have used, so probably there we could be maybe rest assured. Antimicrobial activity, antimicrobacterial activity. I know that there are some generations of quartz which claim to have, but I'm not sure. I need to do a bit more reading. I'm never sure about antimicrobacterial until I have read it very well. Spore-bearing organisms. I think that's also another very important thing that is, there within healthcare settings in India. Clostridioides difficile, if I may say so. C. auris, some of us have worked, I guess. Maybe it's a good thing if it has action against C. auris, because that's another bug that we are very, very concerned about. And another angle that we probably, maybe need to look at is community care. Because flu in the house, once it enters, it ensures that everyone in the house has had a round of flu, and then only will it go. So whether community care, there it has any role. So those were my probably final comments. I thank the Microgen team for giving all of us an opportunity like this, and there's a lot of deliberations and to do about this exciting innovation. Thank you.
Thank you, Microgen, and thank you all the audience, and thank you all the panelists actually coming, and we have a great discussion here. Thank you. Over to Microgen team.
I must thank Dr. Bansi for giving me a call while I was still traveling to be part of this exciting discussion. Thank you so much.
He is not coming, then I am also not coming.
All the queries what you have, so it can be solved only when we have multicentric trial, and we put it on the larger this thing, not on the lab trial in the real condition. I'll be very happy, right? So
but last time you told Delhi will be separate multi-center, Mumbai will be separate multi-center.
Yeah. Yeah, yes. Yeah.
All the four zones.
I think together. Dr. Yatin Mehta called today once again on this subject. He wanted to organize it immediately.
Yes, maybe actually ISCCM has a very good research wing, and they do a lot of projects. So, it could come through ISCCM. They do a lot of projects. And Yatin Mehta sir is associated with ISCCM. Dr. Subhash Todi is there in Kolkata. So, get a project rooted out through them, and probably a lot of institutions will actually, get in. So, meaning they can have people kind of brainstorm on what the project can really be.
Yeah, Dr. Subhash Todi, we are meeting him. He is going to be a chairperson at Kolkata meeting. Right, 29th we have a clinical meeting, CME at Kolkata. And Dr. Subhash Todi is going to be chairperson over there. So, Dr. Bansidhar, thank you. Thank you very much.
Ma'am, I have one question. So, we are not very sure about the 7-day effect. But one thing is sure that the potency goes away at some point. And also about the concentration, that particular concentration for particular days is we can assure. So if we will continue our routine cleaning and disinfection, so we all use multiple disinfectant, we use hydrogen peroxide enzyme based and other things also. Will any of this disinfectant will reduce the concentration or potency of this much before day 7?
So that's what I said, the compatibility. See, if you're going to have a one protocol, as Shripa mentioned, you have to modify your SOPs. And you modify your SOP for a long-acting agent and then have another agent, or have the same agent without the long-acting activity. That's one point that, yeah. Yes, yes.
So,
Rightly pointed out, once you applied it, whether the sodium hypochlorite will damage it and reduce its potency. So that is also my concern actually. Yeah, you are rightly pointed out.
And so multiple cleaning might reduce the concentration
Yes,
the required
yes.
and will add to the resistance then.
Yeah, yes.
But there's a multiple cleanings meaning we would
yeah,
want to
yeah,
naturally continue the
definitely.
process of cleaning.
I understand the concern raised by doctor. Because in the hospital, the various disinfectants are used and you need to have your own cleaning protocol. So this product, see, if you see the quad is a tasteless, smellless, colorless, and the non-reactive, right? So it doesn't react with this thing. We have a lot of metal compatibility reports, right? It is a titanium, steel, cadmium, everything. We have around 10 different metal and surfaces where we have metal compatibility report from the US, right? So, and as far as the use of the other disinfectant like the hypochlorite and all, they are as such as a bleach, right? And the reaction with this thing, because this product has no this thing once it is there, but we still need to really work on that, right? This is a good food for thought.
The issue,
Multicentric study you can point.
yes, the issue
Yeah,
is that,
yeah.
when you have surfaces that are
Yeah.
not visibly clean,
Yeah,
you need to clean.
yes. yes, I
So
understand.
that cleaning process
Yeah.
needs to be there, and
Yeah.
whether cleaning will have any impact on
Yeah.
this process.
I was doing a clinical trial at Lucknow and one medical college, and I was in July last month only. So we took a ICU, and the most exposed place was a medical college and the huge crowd, and there was no controls. So we exposed this product to a surface, and I asked the ICN and the microbiologists and all these places, the surface which was close to the reception where everyone goes. And you leave this surface untreated, and if you are doing a cleaning, only a cleaning you are doing it, it will really will help. And so the report is very encouraging. I have the report. I'll share with you once we have in this group that it was a surface which was a high-touch surface in ICU when the people come and meet the nursing staff over there, and when the people coming and moving, and it was a very, very crowded place where I was doing this trial, and very crowded, and I was feeling suffocated so much, right? But the product has performed really well, and regarding the metal compatibility, we have fantastic reports. And the another thing which I think panel wanted to know, this product has a soil load tolerance up to 98%, right? If the surface is contaminated already, so this product works. We have a report which says, a report once again from the US, they say this product works up to 98% soil tolerance, right? This report we have, all international laboratory, we'll be happy to share with you. Right? Any more question? Yeah.
Yes. What a discussion. What a panel discussion. Everybody, present over here is really proud, and we really had a wonderful discussion over here. We thank all the panelists for sharing their valuable thoughts, sharing their time. Now we have a bit of a surprise. The surprise is we have a beautiful cake coming on to the stage, and we would request our panelists to please come forward and have this cake cutting ceremony in front of us. May I request all our panelists, please?
Yeah, ma'am. Please, please. Yeah, please.
मैडम मैं साथ में हूँ। हम लोग हैं आपके। मैडम आ जाइए।
तो मुझे आप एक्सक्लूड कर दो। मैं भी एक्सक्लूड होगा। ओके।
This is the celebration for Dr. Faridi.
Thank you very much. Yeah, ma'am.
आपने लिया है? पहले माइक्रोफोन ले लेने दीजिए सबसे। उन लोग ओके करेंगे तभी हम
Thank you so much. I would now request our panelists to please take their seat. We take the pleasure of inviting our Honorable CMD Dilip Bhai Parekh to the podium for proposing the vote of thanks.
Thank you very much, all the distinguished panelists. I am really touched with the kind of discussion what we have, brainstorming discussion. A lot of insights were there, and of course I have no such huge background as far as the microbiology is concerned. But whatever I could understand, there are so many things that we learn today, because running an organization is one factor, and what is the practical difficulties as far as handling the microbiology as well as the cross-contamination and contamination. I really appreciate, thank you very much. One last thing I would like to add here. This being a made in India product, make in India product, there are, see, couple of panelists as well as couple of people have raised this question earlier to me. The kind of wow feeling. Is it true? This kind of residual effect of 7 days, whatnot. I am simply, bit concerned about this remark for a simple reason that had this would have been from any US organization or any European company, this question would not have been raised. The sheer dedication of my F&D team, my entire team, Dr. Faridi, my Jash Parekh, etc., they have done so marvelous job. And with their sheer dedication and impact and the zeal of working on the project has come out with one of the fantastic product. Of course, I am the person and Mr. Faridi, we have started this organization way back in the year 2006 with Microgen Incorporation was the original company with single product D125. I would like to add one more last thing. D125 we carried out, we were talking about, mutation, or we were talking about whether this is going to have tolerance, but to the surprise of everyone, inclusive of us, we all, day by day we are marching. Today we are in the year of 17 years. Not a single resistance took place as far as D125 original product is concerned. This is the credibility and this is the extension. Mind you, again I am telling you, this is the extension to D125, and whatever the new addition what we have introduced today is definitely going to, this is my gut feeling. Though this is my baby, I should not boast all, so many things in front of such a distinguished panelist. But whatever experience I have gathered of this industry since last 17, 18 years, this is a blockbuster product, I am telling you. Seeing is believing. Kindly take trials of all this, then you yourself probably might come out with one of the fantastic remarks that this is the product what we entire world is waiting for. Last thing but not least, this being an Indian product, we should be proud about. Why? Not a single effort has ever been made by any Indian company to come out with such a fabulous product. This is yet to be proved whether this is fabulous or not. But to me, this kind of effort what we put in, and after putting all these efforts, whatever the end result what we have obtained so far, whatever trials has been taken by various distinguished people like you, as well as whatever we have taken the trial at our lab, has proven one of the fantastic product. So I humbly request you all, kindly take trial of all this. The way you want, take the trial. Then you will believe that, because this question was quite oftenly asked to me, is it true? So let you see yourself. Seeing is always believing. So kindly, it is my humble request, please take trial and then take the certificate, give us the certificate whether this is the right product or not. Thank you very much, gentlemen. One last thing, there is a dinner out here, so you all are cordially invited to take a dinner. Am I right? Thank you very much.
Thank you, sir. But before going, I would request, sir, to just help us. We have a token of compliments for our esteemed speakers, panelists, and I would like to call upon, if you can come over here, sir. May I call upon Dr. Aruna Pujari for a small token of compliment from Microgen.
Thank you very much.
Dr. Bansidhar. Can we have a round of applause for Dr. Ami Varaya? I would like to call upon Dr. Shripad. Dr. Tejas Gohel. Dr. Milind Ubale. Thank you, sir. It was a wonderful discussion. Dr. Urmi Shah. And last but not the least, Dr. Rahul Kamble. Thank you, sir. Now I would like to request all of you if we have a dinner spread out. Thanks for coming, and we really look forward to hear from you with your experiences very soon. Before going, may I request all of you to please fill up a feedback form. Your feedback is very, very valuable for us. It is inside the kit that we have given. That would be really booster for us, your frank and feedback. Thank you so much. Kindly fill the feedback form and share to us. That's really valuable for us. Thank you.